Hello, everyone. Thank you for being here. I'm Lisa Myers, Program Officer on the opioid team, and this is Stigma, Substances, and Policy, How Language Drives Change. All participants are in listen-only mode. It's up to you and your preferences if you want to have your video camera on or off. We do ask that you use the chat box to ask questions and to participate. It looks like many people have found that chat box, but if you haven't yet, please go ahead and find the chat box and tell us your name and organization. And then also we'll be sharing a survey throughout the webinar. Please make sure that you fill out that survey before you depart today. We do value your feedback. It helps us know that we are hitting the mark and that we're providing technical assistance and education to our partners that is useful. Next slide, please. So again, this is Stigma, Substances, and Policy, How Language Drives Change, and our presenter is Dr. John Kelly. Next slide. I know I've seen many familiar faces on the registration sheet, but there were also a lot of new names as well, and many people who hadn't heard of Interact for Health. So really quickly, Interact for Health promotes health equity to improve the health of all people in our region. We do this through grants, education, research, policy, and engagement. Interact for Health is operating towards the end of our strategic plan. We have 3 pillars that we work in: reducing tobacco use, school-based health centers, and the work of our team addressing the opioid epidemic. This is our 20-county service area. So as you can see, we serve southwestern Ohio, southeastern Indiana, and northern Kentucky, so the greater Cincinnati area. This is the team. So we have Sonia Carrico, Senior Program Officer, myself, Lisa Myers, Program Officer, Michelle Leidenberg, Evaluation Officer, and then our intern, Sachi Badi, is also on our team and helping control the slides today. And really quickly, this is our team's kind of structure that we work in. Our goal is to reverse the trend of overdoses and deaths from opioids. We take a comprehensive approach. So we use harm reduction strategies, we support quick response teams and other programs that connect people in crisis to care. We also work to reduce overdose and relapse once people have found care by recovery support, recovery housing. We also work to remove barriers to increase access to treatment. And then our cross-cutting strategies are data, technology, and reducing stigma. Next slide. And now it's my great pleasure to introduce Dr. Kelly. Dr. Kelly is the Elizabeth R. Spallin Professor of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He is also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital, the associate director of the Center for Addiction Medicine at Massachusetts General Hospital, and the program director of the Addiction Recovery Management Service. He has served as a consultant to the U.S. federal agencies and non-federal institutions, as well as foreign governments and the United Nations. Dr. Kelly has published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine, and was an author on the U.S. Surgeon General's report on alcohol, drugs, and health. His clinical and research work has focused on addiction treatment and the recovery process mechanisms of behavior change, and reducing stigma and discrimination among individuals suffering from addiction. Thank you for being here, Dr. Kelly.
Thanks so much, Lisa. I hope you can hear me okay.
Yes, we can hear you. Thanks.
Good, fantastic. Will you be advancing my slides, or shall I advance them from here?
Just say next slide. Sachi will be advancing them for you.
Fantastic, great. Well, I'm really delighted to be here. Lisa and the team, thank you so much for the opportunity and invitation to be a part of the proceedings this afternoon. And delighted to talk about this topic. It's a topic that I kind of, when I entered the field 30 years ago or thereabouts, I really wasn't ever thinking about language and the significance of language really, or stigma and discrimination at that point in my career. And it's only really kind of midway through my career I started to realize the significance and importance of language, particularly some of the stigmatizing language that was pervasive in the addiction field. And it's something that got my attention. I started to think about, write about, then research about. And it's that story what I'm going to tell you today in terms of what we've all learned in the last 30 years, but really zooming out over the last 50 years to understand exactly uh, how how our language both reflects and affects our approaches to endemic drug and alcohol problems. As Lisa mentioned, I am the director and founder of this Recovery Research Institute, and if you hit next, yeah, thank you. No, just about. It's just to highlight that if you're interested, we publish a free monthly bulletin, recovery bulletin, which translates the latest science on treatment and recovery for opioid, other alcohol and drug use disorders. It's designed to be easily readable, digestible, and hopefully helpful to individuals in or seeking recovery, family members, as well as treatment providers and policymakers and peer support specialists. So it's designed to be easily understandable. So please avail yourself of that if you wish. Next slide. So as I mentioned, it's interesting. Here we are 50 years on this year since the declaration of the war on drugs under Nixon. And I've been reflecting on this milestone and kind of putting this in context here, what I'm going to talk about today. Why are we talking about this issue now? That's always a good question. And why not before? And really addressing it very squarely, as I'll talk about today, how everybody seems to be up in the ante in terms of recognizing the significance and importance of language. But 50 years ago, when Nixon declared the war on drugs, I think we normally associate that, of course, with some of the harsh punitive legislation that has been passed, like the Anti-Drug Abuse Act of the early 80s, mid-80s, which introduced these mandatory minimum sentences, which disproportionately affected particularly minority men. And we don't often think about all of the other things on the other side in terms of treatment, what they call demand reduction, that is to say, treatment, prevention, and recovery support services, and all the things we've learned there. And we've learned a lot. At the same time, in 1971, the National Institute of Alcohol Abuse was founded. In 1974, the National Institute of Drug Abuse, which has produced 90% of our knowledge in the last 50 years. All the things we've learned about addiction worldwide has been produced through those two agencies, courtesy of the American taxpayer. Next slide. There's many things we've learned, and I'll just kind of go through some of the things I think that we've learned which pertain to this issue of stigma and discrimination. One of the things that we've learned, very importantly, is like other complex illnesses, addiction, substance use disorder, is influenced by genetics. Roughly half the risk of contraction of a substance use disorder is conferred by our genetics, something we did not know 50 years ago. Next slide. Of course, it's not a genetically determined illness. It doesn't mean that if you have genetic predisposition that you are going to develop it, but rather you are at 4 to 8-fold increased risk of developing it if you have those genes and you meet the other conditions. And some of these other conditions are highlighted here. And we know that it's called, substance use disorder is what we call a complex illness, like all psychiatric illnesses and like many physical illnesses. It's a combination of our genes and the environment over time. And sometimes these are called epigenetic effects. That is to say, the environmental exposures and changes throughout our life course influence the genetic manifestation of our genes, what we call phenotypes or epigenetics. So, and you can see here the complexity of it, like the multifactorial influences on drug use. Exposure to drugs, particularly early on in the life course, particularly during adolescence. Earlier exposure increases the risk uh, over and above our genetics. So it actually increases the risk, the type of drug, the route of administration. All of these factors, of course, influence the damage that it does, whether certain genes are turned on or not. And that exposure changes our brain, and we call this addiction. These brain changes that occur as a result of chronic exposure to substances change the brain through processes of neuroadaptation, neurotoxicity, and that can lead to alcohol or other drug use disorders. Next slide. We've also learned in terms of the controllability of substance use disorder and substance use. You know, the question is, why is this a psychiatric illness? Why is substance use disorder in the DSM, for example? Why is it a psychiatric illness? The reason why, of course, is there is an involuntary aspect to it. If it was purely a matter of voluntary control, it would not be. It would be a matter of choice. It would not be a psychiatric illness. The point is that there is increasingly impaired control over use despite harmful consequences, and this is what we call substance use disorder, or in the severe end, addiction. And we've learned a lot through brain imaging technology that was only available on autopsy when people died. Now we can see inside the living brain, both functionally and structurally, to understand exactly where in the brain the neurocircuits that are affected through chronic exposure. This is something we didn't know 50 years ago. Next slide. Epidemiological risk factors. Again, we have become so much more keenly aware of the risk factors associated with the onset of substance use disorder. What kinds of socioeconomic conditions, demographics are associated with higher risk? Next slide. And we've also learned about the prevalence of recovery, not just substance use disorder, which we know there are about 20 million people each year in the United States who meet criteria for a substance use disorder. But we're also learning what proportion of people are actually in recovery from a substance use disorder. Next slide. We have learned, for example, using a nationally representative study of the US adult population, that roughly 9%, or 22.5 million people, have resolved a significant drug or alcohol problem in the United States. Next slide. We also know and have learned that there are many different pathways to recovery. I think where our cultural default is when we think about addiction, we tend to think about going to rehab and going to AA, perhaps. That's kind of our cultural default. That's what you do when you've got an addiction problem. You go to rehab and then you go to AA. That's what you do. But in reality, that is certainly what some people do and need, and they do well when they're engaged in those pathways. But by a long shot, that's not the only one. In fact, that's probably a minority of people who actually utilize those kinds of pathways into recovery on the severe end of the spectrum. But there's a vast array of other individuals who suffer from less severe drug and alcohol involvement and impairment. And many of these individuals follow pathways into recovery, out of addiction into recovery, through non-clinical pathways by utilizing community resources, mutual aid groups, without stepping foot inside clinical arenas, as well as people do not use, many people recover without the use of any external services. In fact, we have found in our national recovery study that roughly half of individuals who have recovered from a serious drug or alcohol problem did so without the use of any external resources. Interesting. And those individuals tend to be less severely drug involved and less severely impaired, as you might guess. They also have more resources at their disposal to help them in their recovery attempt. Next slide. So we've learned a lot of things. We've learned a lot of things about treatment in the last 50 years. We've learned, some of you may recall in the 80s, 1980s, we had this model of the stages of change, which strongly influenced our whole schema of understanding and thinking about how people change behavior through this pre-contemplative stage, or sometimes people will call it denial. Contemplative stage, where people are thinking about change, preparation, where they're preparing to change, action, and then maintenance. And this has led, of course, to this recognition of particularly the pre-contemplative and contemplative stages of change has led to important interventions like motivational interviewing. Next slide. Which really grew up in the 90s and was designed to not give people a good talking to, but rather to give people a good listening to, recognizing that many people, not all, but a large chunk of people coming into treatment have this ambivalence about change. They're kind of pre-contemplative, I do and I don't, not quite sure. My spouse or the court or my employer or somebody wants me to be here. I'm not really sure I want to change. So this whole notion of motivational interviewing, meeting the person where they're at, to look the world through their eyes and help empathize more accurately and help them move towards adaptive change. Next slide. We've also had relapse prevention come along in the 80s. Next slide. Cognitive behavioral relapse prevention, contingency management, probably the most effective behavioral treatment that we have. Again, only in the last 35 years, 150 trials show this is a very effective treatment. Next slide. Mutual aid groups and research, importantly, research on these mutual aid groups, particularly AA, the biggest and the oldest and the most influential. Now we have very strong evidence to indicate the clinical and public health utility of these mutual help groups, particularly Alcoholics Anonymous. Next slide. We've seen the birth and growth of and diversity of medications to treat addiction, from methadone in the 50s through more recently buprenorphine and extended release naltrexone for opioid use disorder, Narcan, the overdose prevention drug, which is naloxone, and then 3 FDA-approved medications to treat alcohol addiction. Next slide. Harm reduction has been critical in terms of reducing overdose deaths, preventing the spread of infectious disease, meeting people where they're at, helping them to change behavior, to engage with services, to reach remission sooner. Next slide. And very importantly, I think, has been the recognition of understanding addiction as a chronic illness in its severe form. And this is what we see, and there's been this notion of the need for not just 30 days of treatment or 90 days of treatment, but really at least 5 years of ongoing recovery management and monitoring. Next slide. We've seen also this shift in language and rhetoric. And I mentioned earlier that we've seen a lot of things change over this last 50 years as we've learned a lot since the war on drugs was declared. Now, Nixon famously, back in 1971, called drug abuse, quote unquote, public enemy number one. Again, invoking that idea of a kind of a militaristic, a law enforcement approach to defeating the war, to winning the war, was going to be capturing, if you will, the drug abuser or addressing, quote, drug abuse. I don't think we would use that. I don't hear that kind of language these days. I think we're more likely to hear these days that addiction or substance use disorder is our top public health problem. And certainly, I think most people would agree today when you combine not just the opioid overdose crisis, but all the 100,000 alcohol deaths every year, the 400,000 tobacco-related deaths, as well as tens of thousands of deaths related to other drug use, that this is our top public health problem. Next slide. What has changed is our relative emphasis, and I think that language reflects this legislative shift and cultural shift in many ways, away from the harsh and punitive laws and rhetoric of the war on drugs towards what we call demand reduction laws. That is to say, increasing insurance coverage and parity for insurance coverage to treat mental health and addiction disorders. You can see this highlighted here. Beginning earlier on, since the declaration of the war on drugs, there was the harsh punitive sentencing laws. Next, hit the enter button. And this moved towards Mental Health Parity Addiction Equity Act, the Affordable Care Act, which required insurance companies cover substance use disorder. So that was a major shift because it meant people could get covered, could get treatment for a substance use disorder to, again, increase what we call demand reduction, prevention, treatment, recovery support services. Next slide. Think what's happened also in terms of our legal approaches. You saw how that legislation has been passed, major legislation regarding our approaches. And again, this all pertains to how we are addressing addiction. This was the first ever, highlighted here as the first ever drug policy reform summit since the declaration of the war on drugs. This was held at the White House on December 9th, 2013. I know because I was there. I was invited to be there. In fact, I was asked to present some of the data that I'm going to present to you today. The reason why there was this formal shift at the White House, at the federal government level, was because they recognized that the harsh, punitive rhetoric and approaches associated with the war on drugs had not worked, was not working, and needed to be expanded to incorporate a broader public health framework. Next slide. A couple of years ago, I was again talking about this issue of stigma and discrimination in Vienna, Austria, the United Nations. What's significant here is this coming out of the United Nations building here. On one of the days I was there, I noticed this monument outside. This is the only monument outside the United Nations building in Vienna. Look at this. It says dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. That's an interesting and for me a very poignant monument that it is the only one outside. And of course, it's worldwide. This problem is worldwide. And this is recognizing that this is a global problem about which we need to do something about and something in the realm of public health. Next slide. We've seen this shift also in the criminal justice system. Instead of locking people up, now there are drug treatment courts so that people end up in the judicial system because of a drug or alcohol-related incident or crime. They can be directed into a court system where they can get treatment. Next slide. Not only at the court level, but at the frontline law enforcement level. Some of you may have heard of this fellow. His name is Chief Campanello. He's from Gloucester, Massachusetts. And he made national headline news about, 8 or 9 years ago now, because he was sick and tired of arresting people with drug possession and addiction problems, only for them to be arrested very shortly thereafter. He said, this is not working. I need to do something different. So he instigated this ANGEL program, this idea of help, not handcuffs, advocating that if you came to the police station, they would get you into treatment, would not arrest you for drug possession or drug charges. Again, 30 years ago, 20 years ago, 50 years, we would not, this would have been so far out there, it would have been, astonishing. Now it's kind of par for the course that more and more frontline police officers are becoming, by necessity, public health commissioners. Next slide. We've also learned that addiction, the clinical course of addiction, that is to say, severe substance use disorder, the kind of individuals that we typically see in our specialty services, the clinical course tends to be a long one. And this is in part because of stigma and discrimination. If you look on the left-hand side of this graphic, you can see it takes about 4 to 5 years after the onset, after people meet criteria for a substance use disorder, before people start seeking any kind of specialty care. Now, part of that is because of the fear of discrimination that they would experience if they were, number one, to acknowledge it to themselves, number two, to disclose it, number three, to ask for help. because it puts them at risk potentially for repercussions because of the stigma and discrimination. So this delays help seeking. It also leads to increased risk for dropout from treatment. Also, you notice in the middle here, it takes about 8 years and about 4 to 5 treatment episodes after people start seeking help. These are adults with addiction. And that's a long time before reaching that 1 year of full sustained remission. Now, people are making a lot of progress during that time, but still, that's another 8 years on average in adult clinical samples to get that 1 year of full sustained remission. And here's the other thing. Look on the right-hand side here. Even after people reach that 1 year of full sustained remission, it can take an additional 4 to 5 years of continuous remission before the risk of meeting criteria for substance use disorder in the following year drops below 15%. Why 15%? Because 15% is the annual risk in the general population of meeting criteria for a substance use disorder in any given year. So to be no more likely than anybody else in the general population of meeting criteria for a substance use disorder if you've already had it takes an additional 4 to 5 years after you've achieved that first year of sustained remission. Now, this means, of course, that we need to provide services, as I mentioned, over the longer term, not just for 30 days or 90 days, but to provide services that can help people to hopefully get to that same population level sooner. And I think there are things that we can do to do this. One of the factors regarding stigma and discrimination is that it leads to more shame. It leads to less self-disclosure, both during asking for help and also in recovery, disclosing the fact that people are in recovery and needing the services there. People face discrimination even when they're in recovery and in recovery for many years. So this is something we need to do. We need to do something about. Next slide. So what is stigma? Well, we can think about stigma as an attribute, behavior, or condition that is socially discrediting. Next slide. What is discrimination? It's the unfair treatment of individuals with that stigmatized condition or problem. Next slide. And there are many different consequences, of course, to stigma. Some of them are quite obvious, some of them less so, perhaps. One of them, of course, at the public level, is that the degree to which we stigmatize these problems and how we frame them. Should they be punished, for example, or should we provide prevention services, treatment services, recovery support services for people who meet criteria for substance use disorder? That's a policy question, and there's a lot of funding that can be attached to it. And so how we frame it and how we contextualize it, conceptualize it, how we talk about it, influences those big decisions. At the personal level, as I've already alluded to, people feel stigmatized. They're more likely to feel shame, differentness, apartness, more likely to be secretive about their use, less likely to disclose it, less likely to acknowledge it, less likely to seek help and to delay seeking help, as well as to drop out of treatment sooner. Next slide. And these are the commonly studied dimensions of stigma. Stigma is hard to measure behaviorally in the real world. There are ways of doing it, but most of the ways that we have measured stigma is through stigmatizing attitudes. And it's these dimensions of attitudinal dimensions here, which are usually measured, and I'll talk more about that in a minute. But typically, there's these dimensions of blame. Are they responsible for causing their problem or disorder? Can they get well from it? That's the prognostic optimism or pessimism. Will they ever recover? Will they ever be normal? Are they trustworthy? Can they be trustworthy in the future? And the two last ones, dangerousness and social distance, are related. Are they unpredictably volatile? Are they a threat to my or others' safety? And therefore, should there be more social distance? Would I have them, for example, would I have this person with the stigmatized condition be a babysitter, marry into my family? Would I take them on as an employee, etc.? And these 4 different dimensions have been studied in many different studies pertaining in a way to measure stigma and discrimination. Next slide. Now, we do know that internationally as well as nationally, that substance use disorder and addiction is the most stigmatized condition across practically every society that's been studied. This was a study done by the World Health Organization, 14 different countries, 18 of the most stigmatized conditions, including being HIV positive, having AIDS, being a criminal, as well as being addicted to illicit drugs, and as well as licit drugs like alcohol. And top of the list, universally across these 14 countries, on 18 different stigmatized conditions, illicit drug addiction was number 1, alcohol addiction number 4 out of this list of 18. Next slide. Studies have also shown that substance use disorder is more stigmatized compared to other psychiatric disorders, in part because people view people with substance use disorders as more to blame for their condition. And you can see why, of course, because it involves taking something from outside of our body and putting it into our body. And so that involves initial choice. This is where genetics come into play in influencing the degree of relief as well as degree of subjective reward that people experience. And I'll explain more of that. But people don't know that they're experiencing that greater level, that deeper level of reward just by virtue of their DNA. They don't know it. They have nothing to compare it to. They just know that they are experiencing something quite profound. The more profound people experience those initial exposures, the more likely they are to repeat it. Describing substance use disorder as preventable, as treatable, that people can recover, does seem to help in reducing stigma. We also know that patients themselves who are addicted, who themselves hold more stigmatizing views about substance use disorder, are less likely to seek treatment and to discontinue sooner. And we also know that clinicians, physicians, clinicians, psychologists, psychiatrists, social workers, counselors, all have, just like other members of the general public, can hold stigmatizing biases, viewing patients typically as unmotivated, dishonest, and manipulative. One shining light, however, in that realm is that education can help with this clinical bias and this discrimination. Though training and educating clinicians about the nature of substance use disorder, what it is, how it's caused, how it influences, how it presents, can actually help reduce clinical stigma in a clinical setting. Next slide. So I've alluded to this already, but why is addiction so stigmatized compared to other social problems and health conditions and other mental illnesses? We see this top of the list time and time again as the most stigmatized condition in many different societies around the world. Next slide. I think it's because there are 2 major dimensions, and I've alluded to this a little bit already. 2 major dimensions which influence the degree of stigma. One is cause and one is controllability. If we can say it's not their fault and they cannot help it, stigma tends to decrease. On the other hand, if we say it is their fault, they did cause it, and really they can help it, they're just engaging in willful misconduct, then stigma tends to increase. We have less compassion and empathy for people if we feel like they caused it themselves and they really can help it, but they're just engaging in willful misconduct. Next slide. And so this just shows the relationship between these 2 different dimensions. Next slide. Now, I alluded to this already, and this is one of the things we've learned about addiction in the last 50 years since the birth of NIAAA and NIDA regarding the genetic contribution to addiction. As I alluded to, our genetics influence how we respond to exposure to substances. Some people are naturally protected. They don't have to try very hard not to be addicted because they're never interested that much in alcohol or other drugs that they may be exposed to. But for roughly 15% of the population who are exposed, who have this genetic predisposition, as I mentioned, they experience something very different, very profound, It can be ultra rewarding or ultra relieving. It may alleviate a certain amount of burden, a psychiatric burden or symptomatic burden or just angst, or produce this profound experience of reward. And they don't know they're experiencing it differently than other people. They just know they like it and they want to repeat it. And it's that repetition of exposure ultimately, and the neuroadaptations that go along with that exposure, of course, which leads to increasing doses to get the same effect as you did when you first started, and those brain changes which lead to addiction. Next slide. In terms of the other dimension, so I've talked about the cause dimension there in terms of genetics. The controllability, again, we've learned a lot about this issue of controllability. As I mentioned, the reason why it's a psychiatric illness is because over time, yes, of course, when people start to use, they are making a choice to use. But in the end, when people are severely addicted, they are choosing not to use. They're saying, I don't want to use, I want to stop. But the locomotive that they're on has got so much momentum that they're unable to put the brakes on and stop. Time and time again, people will swear off, will try to cut down, will try to stop, only to break their promise to themselves and to others. This can be very, very demoralizing and disheartening, and they can't really understand why. We now know why, in terms of the neuroscience of the impact of chronic exposure to substances in the brain, in these neurocircuits of reward, memory, motivation, impulse control, and judgment. And these neurocircuits are affected and sometimes radically affected in severe cases in a dose-response fashion, typically, as people are more and more exposed. And this, of course, affects the ability to self-regulate the impulse to use drugs despite harmful consequences. And this is what we call addiction. Next slide. Not just functionally, but structurally. You don't have to look very long or very hard here to look on the bottom right. Look at somebody with chronic alcohol exposure compared to someone with very little alcohol exposure. You can see the structural changes in the brain, the cortical enlargement, the cortical shrinkage, the ventricular enlargement, which is typical of the cellular changes and structural changes in the brain as a result of chronic exposure. You don't have to look long or hard to understand that there is a difference here as a result of exposure to alcohol, which is a neurotoxin. Next slide. So what can we do about it? What can we do about all this stigma and discrimination? Now, as I've mentioned, we've come a long way, right? We understand much more about the causes of addiction, that is genetically influenced. Roughly half the risk is conferred by genetics, but it's multifactorial. It's not just genetics. Just because you have the genetic predisposition does not mean that you're going to get it. Even in identical twins, clones, they'd only half the time they're going to both get it. So there's a strong environmental component too, and this is why there's things that we can do to prevent substance use. But certainly we do know that these three things seem to have an effect on stigma and discrimination. I mentioned one already, that's education. So when we educate people more, none of these are the whole story in terms of mitigating stigma and discrimination, but they can help a bit. Educating people about the nature of these conditions, as I've tried to do today, can help to diminish stigma. Personal witness is another way that's been very successful, probably the most successful in terms of dismantling stereotypes that people have. This has been a major thrust, of course, of the recovery movement in the United States and now in other countries around the world. The idea of people speaking out about their addiction experience and recovery from it. There's a large organization you may know called Faces and Voices of Recovery. They are celebrating right now a 20-year anniversary in a couple of weeks. Virtually, it was going to be back in Minnesota where it was formally launched 20 years ago. But Faces and Voices of Recovery, the idea that speaking out, putting a face and a voice on recovery helps to disabuse people of the kind of faulty stereotypes that people may have about, quote, what an addict looks like. And the other way, which I'm going to talk about more now, which is our language and terminology. As I mentioned, our language not just reflects our definition of things, but affects going forward, how we approach and conceptualize problems and people suffering from these disorders. Next slide. So let's look at education for a second. I told you this wasn't as simple as we'd all like it to be. And here's a good example. I'm going to show you 3 examples here. First of all, in the mental health field, there's been many studies looking at other psychiatric illnesses beyond substance use disorder. So the idea here is if we emphasize the biomedical aspects of mental illness, will we see a decrease in stigma? Because people will blame people less if they know that there's some kind of biomedical cause or biogenetic cause. Next slide. So this was a systematic review of 28 studies, 28 different studies, which looked at this issue of emphasizing the biogenetic component to mental illness. Like substance use disorder, many other, if not all, mental illnesses have a strong genetic component. So if we were to emphasize that genetic component, what happens to stigma? Well, it turns out when you look across these 28 different studies where this has been studied and been examined, they found, yes, it actually did reduce stigma regarding blame. Okay, so emphasizing the genetic components regarding mental health did reduce the blaming stigma. So that's good news. That was the intention. But however, the kicker here, look at the bottom left, it increased those other dimensions of stigma. So if people, even though people said, well, okay, they're less to blame for having the disorder, but I don't want to be around people who have that disorder. I think they're dangerous, and I don't think that they can get well when we emphasize the biogenetics. Interesting. Next slide. So not as simple and universal as we might hope. What about the neurobiological impact? So this is kind of the controllability aspect I was talking about. What happens if we emphasize the changes in the brain as a result of a psychiatric illness? Because we know there's these kind of chemical imbalance, this idea of chemical imbalance, if we emphasize that part in the brain. What happens if we emphasize that? And this was a study, a systematic review, where they looked at 26 different studies. Again, what they found here, that this had no effect on blame in this one. So it didn't affect the stigma regarding blame. And it actually, again, increased the perceptions of social distance and dangerousness and the fact that people could not get well. So not exactly what we would think, right? When you think about, well, if we emphasize these biomedical aspects, we're onto a winner. In some regards regarding blame, yes, but for the rest of the other dimensions of stigma, it's actually having the opposite effect. So there's implications there. Next slide. Now, we just did a big study, national study here in this regard, but with addiction. So here's a study where we looked at, next slide, 6 different ways of describing addiction. Now, I was very interested in looking at, does it matter what kind of terminology we use in our field to describe people or describe the disorder itself? For example, if we describe it as a chronically relapsing brain disease, like many health agencies do, or a brain disease, or just as a disease, or as an illness, or as a disorder, or as a problem, would we get different, if we described it differently, using one of those different terms, would people view people who had that disorder, that disease, would they view them any differently regarding these dimensions of stigma? Next slide. So what we did was we had a very large sample of 3,600 people. These were a nationally representative sample of the U.S. adult population. And we created a vignette, which you can see here on the right, describing someone in treatment with an opioid-related impairment, but the person was being taught while they were in treatment about the nature of their condition. And the only thing that changed in this vignette that was randomized was the term. So Alex was taught about his opioid-related impairment as a chronically relapsing brain disease, or as a brain disease, or as a disease. So each one of those terms was inserted at random into these vignettes, and those were randomized to people so that there was roughly 600 people got each one of these terms, and we were able to look at the impact of being exposed. The participant reading this vignette described as one of these terms, opioid-related impairment, described in one of these ways, and to see if that had an effect on their judgments of stigma regarding Alex. Go next slide, please. Interestingly, very similarly to what they found in the mental health field, we found some similarities. So when we look at the more heavily loaded medical terminology, like chronically relapsing brain disease, you can see at the top graph there. When we look at the blame factor of stigma, we see that actually when people were exposed to Alex and his opioid-related impairment as being described as a chronically relapsing brain disease, people blamed him less or her less. However, when it was described as a problem, you see that on the right-hand side, Alex having an opioid problem, people blamed Alex more. And you can see that the other ones were kind of in between. Now look at the bottom. The exact opposite in terms of prognostic optimism, that is to say, the likelihood that Alex can recover. When we emphasized, when people were exposed to that vignette where Alex was described as him being explained, his opioid-related impairment being explained as a chronically relapsing brain disease, you can see the likelihood of him getting well was the lowest. On the right-hand side, when it was described as a problem, an opioid problem, the likelihood of him getting well was viewed as much more likely. Interesting. So different outcomes, different types of stigma are elicited by different types of language. So what this says is that the implications of this are that it may depend, there's no one universal way of describing opioid-related impairment that will optimally address all these different dimensions of stigma. So we may need to tailor our messaging depending on the population, the goal, the context of the communication, to reduce blame. Maybe when we want people to get into treatment and stay in treatment, we might want to emphasize the biomedical aspects. When we want people to reintegrate into society and be able to be accepted in society, we might want to drop the biomedical terminology and talk about history of opioid problems, for example, as opposed to them having had a chronically relapsing brain disease. So there are implications here in terms of how we communicate about people with these conditions. Next slide. Next slide. I just said this, but so I'll skip over that. So what about our language? In terms of how we describe people with these disorders. Next slide. Next slide. Now we know and we hear every day the way that these disorders are described: addiction, dependence, harmful use, abuse, misuse, etc. There's a variety of different terms that are used regarding these particular problems. Next slide, as well as people suffering from them. Thank you. Some of them are more pejorative, some are more clinically oriented and have an origin in the clinical world. Next slide. I guess the question is, does it matter? Here's a question for you, though. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers or alcohol abusers and not as having a substance use disorder? We never refer to anybody who has an eating-related condition as a food abuser. I've never heard anybody say I work in the food abuse field. Universally, the language that has been adopted and that nobody has any qualm or quibble about is eating disorder. That's what we call it. But for some reason, and again, I think this relates to the rhetoric around substance use and the name abuse and drug abuse and calling people abusers stems from the more pejorative viewpoints that started when we started the war on drugs in the 70s, 80s. The idea, of course, was that the view was that people were engaging in willful misconduct, and hence the term abuse. Like a child abuser engaging in abusing a child, a substance abuser was abusing a substance, they had control over it, and they were engaging in selfish, willful misconduct, and therefore should be punished, not treated. Next slide. So is all this language stuff just all political correctness, or is there something more to it? Well, I've already shown you some of the impact of different language, of course, on people's perceptions. But I can tell you, when I started off today, I mentioned that I wasn't that interested in this area, and I'm kind of I'm not a politically correct type of person, except when it comes to this. And the reason why is because I have learned myself through doing these studies the importance of language, and I'll show you why. It does make a difference what language we use, especially, as they say, words matter, especially when it comes to highly charged, highly emotional problems and stigmatized conditions like substance use. Next slide. So think about these two terms, the abuse terminology, or like the food abuser analogy versus eating disorder. Why did they adopt the eating disorder and not the food abuse? I think the abuser term, this is what I postulated many years ago, implies this notion of willfully engaging in misconduct, in selfish misconduct. In contrast, when we use the term substance use disorder, it evokes some kind of medical malfunction just by its very nature, that there's a disorder. Now, we can see, of course, the nature of this disorder these days through brain imaging, the exact nature of it structurally and functionally. So I think it matters in the sense that we may evoke, by using that abuse and abuser terminology, this idea of selfish, willful misconduct. If we were to use substance use disorder, maybe we'd evoke less blame and more likely to elicit ideas of treatment as opposed to punishment. Next slide. So what we did was we did a randomized study 10 years ago. This was a randomized study, just 2 vignettes with the person described either as a substance abuser or, in the other one, described as having a substance use disorder. Otherwise, they were identical. And those were randomly dished out to 600 doctoral level clinicians. These were doctoral level mental health and addiction clinicians. 600 of them. Half of them got the one at random with Mr. Williams described as a substance abuser, half as a substance use disorder. And they were asked to rate whether this person needed treatment, whether he should be punished, whether he was more to blame, etc. What did we find? Next slide. Well, we found that, in fact, as predicted, when describing Mr. Williams as a substance abuser, these clinicians who were doctoral level experts in addiction and mental health were susceptible to this bias to be in favor of punishment. More likely, exactly the same person, exactly the same scenario, just that word change elicited this bias towards greater punishment, more blame, and less likely to exonerate Mr. Williams and to provide treatment. Next slide. When we did a similar study in the general population, next slide, comparing these two terms, again, substance abuser and having a substance use disorder, we saw even larger magnitude differences. Look at the differences here between whether a person who has a substance use disorder should be treated or punished. Big differences in terms of treatment. The person with a substance use disorder was more likely to be viewed as in need of treatment, much less likely to be in need of punishment, less likely to be a social threat, less likely to blame, more likely, vastly more likely to be exonerated, to be viewed with compassion, and less likely to be able to self-regulate use. In other words, they're not just engaging in selfish, willful misconduct. Next slide. So here's the interesting thing here, as I mentioned, even among well-trained clinicians, they were susceptible to this bias at random, just by being exposed to this term abuser. So it says to me that even when we don't mean anything by it, even when we think we're using a term that we know what we mean, we know we're not being stigmatizing, that it can elicit deep down in our language processing centers in our brain. Implicitly, we associate that abuse and abuser term with somebody who should be punished, who's more to blame, who's more of a social threat. And as opposed to using terminology like substance use disorder, where that tends to elicit more of a conditioned response and a schema, activates a schema associated with therapeutic interventions. Next slide. Also, in terms of the word clean and dirty, this is a paper we wrote with colleagues Sarah Wakeman and Richard Sates, colleagues with whom I've had good collaborations with over the years. This notion that we, in the addiction field, in our clinical settings, I have heard, for example, at arguably one of the top hospitals in the world, which is Massachusetts General Hospital, arguably. Many people view it as such. I've heard clinicians at my institution describe urinalysis screens as dirty or clean. Now, we don't use that language in any other area of medicine or psychiatry. Somehow, that street language has made its way into our clinical settings. I don't think we need a randomized clinical study or randomized study to agree that we should not be, at the clinical and public health levels, using language like dirty urines or clean urines when it comes to a psychiatric illness such as substance use disorder. Next slide. Now, in an attempt to try and arrive at a unified language which accurately reflects our current knowledge about substance use disorder, I created many years ago, a dictionary. The idea is that if we want addiction destigmatized, we need a language that's unified and that accurately reflects what we've learned. In other words, we literally have to get on the same page in terms of the lexicon and the terminology that we can agree to use, and that is ideally non-stigmatizing. And that if we know that certain terms are stigmatizing, we should drop them out of our vocabulary because they don't do anybody any good. Next slide. And you can see that, you can look at that dictionary at recoveryanswers.org, and it has about more than 200 terms now. Happy to say Google has adopted the dictionary as part of its Recovery Month activities. Next slide. As well as the, next slide. This is on Google. The American Bar Association also uses our dictionary to educate attorneys in the proper use of language. This has become now pervasive in the, more pervasively used in the criminal justice system. Next slide. Many years ago, I went to Budapest and presented, along with my colleague Richard Sates, to the International Society of Addiction Journal Editors. And what we were doing was advocating for a consensus statement from the International Society of Addiction Journal Editors to really eradicate from the terminology published addiction science worldwide any use of the term abuse or abuser, dirty or clean, out of the lexicon. And they agreed. They wrote we wrote a consensus statement. It was approved. And now across the world publishing of addiction science, these terms are no longer seen or should no longer be seen. The idea, of course, is that if we can remove them from our written texts, we're less likely, of course, to talk about them in the real world. Next slide. In that way. Also, the AP, the Associated Press style book, in the year after that, adopted a consensus statement and in their style guide to eradicate this stigmatizing terminology. That's very important because you think about the press, the media around the world that are writing around the United States that are writing for newspapers, other media online. if they can get it right, they can influence how people talk about it and think about it. Next slide. One thing that we're trying to do right now is, because, ironically, even though everybody in these institutes agree that the term abuse and abuser should be dropped, including the leadership of NIAAA, NIDA, and the National Institute of Mental Health, which have recently published a statement stating this fact, that we should be changing these names, dropping the term abuse out of our national institutes, the National Institute of Alcohol Abuse and Alcoholism, the National Institute of Drug Abuse, the Substance Abuse and Mental Health Services Administration, and the Center for Substance Abuse Treatment. You can see that abuse terminology is still embedded at the highest level, and that's why we're trying to get this change now. Next slide. We have a petition to drop the names. We have now two senators, one from Maryland, one from Michigan, who are have put forth a bill to Congress to change the names of these institutes, to get rid of them. So legislation needs to be passed to change the name. Next slide. And this is our petition. It's Stop the Stigma, End the Stigma. As I mentioned, now we have action at the Senate level at Congress to change these names. We have a bill in the works to put through to hopefully change these names. I think we can reach. I think there's great consensus, bipartisan consensus, to remove these, change these names. Next slide. And again, what to do? You know, how should we talk about these disorders and people who suffer from them? So, you know, our language naturally evolves over time. You know, we don't talk about lunatic asylums or dipsomaniacs anymore. 100 years ago, yeah, that was the common nomenclature. That's what people used. Lunatic asylum was what we call now, of course, a psychiatric hospital. And our language changes, but sometimes our language, beyond natural evolution, needs to change because we have found it to be beneficial to do so. So we need to accelerate the natural change process by saying we shouldn't use that terminology anymore, but we should use other terminology. The mental health field in general, of course, has been doing this for a long time, talking about person-first language. Again, you're not a schizophrenic, but rather a person who suffers from schizophrenia or who has schizophrenia. You're a person who has an eating disorder. You're not a food abuser. So the idea is to use proper terminology to describe the person as a person, who has dignity, and that they may suffer from this psychiatric illness. So there are some good examples here about what to say and what not to say. Now, our language is automatic. So in order to change our language, we actually have to stop and think, I want to say this, but now I need to say this slightly longer sentence instead of calling someone an alcoholic or a drug abuser. They're a person who has an alcohol use disorder or a person in recovery from an alcohol use disorder. In fact, when Faces and Voices sought consultation about messaging, how to tell the story of recovery to the general public, they were told and advised that they should not refer to themselves as an alcoholic or a drug addict, because people in the general public perceive that to be someone who is not in recovery, but someone who is actively still using or is vulnerable to relapse. So instead, they were recommended to talk about themselves as a person in long-term recovery. So whenever you hear someone talk from that vantage point, you'll often hear people say, I'm a person in long-term recovery, a person in long-term recovery from addiction. And again, that framing, the way it is communicated, they did that because they felt that it would have an impact. And in fact, when they did these focus groups, they found that they were right. Next slide. So it does matter. Just some references here for your edification down the road if you want them. Feel free also to email me if you have any questions or want any of these papers. You, of course, I'm happy for you to have the slides that I presented today. If I can help in any other way, please let me know. And hopefully now we'll have time for questions. Thanks, Lisa.
Thank you, Dr. Kelly. If Sachi can just go a little bit further, do you want us to leave that slide up during the Q&A, or should we turn off the sharing? Do you have a preference?
Me?
Yeah.
No, I don't mind. Whatever's good for you.
Okay. Sachi, why don't you go ahead and stop sharing, and then I'm going to turn it over to Sonia. She's going to help moderate the Q&A portion.
Yes, Dr. Kelly, we have a really good question here from Christina. How do the non-clinical pathways view this approach to changes in our language, specifically anonymous organizations such as AA and NA, who focus on the identification as an addict?
Yeah, I think, because though, the 12-step organizations, perhaps other mutual help groups also, and again, this is very embedded in our cultural psyche, in our language habits, still use that terminology. I'm an addict, I'm an alcoholic. I think that will change over time. I think at the clinical level, as people can refer to themselves, of course, racially, ethnically, whatever condition they may have, they have the right to refer to themselves in whatever the way they want. I think at the clinical and public health level, at the professional level, as professionals, we need to make sure that we are not using language which we now know to increase and induce stigmatizing biases. That's really the point. I think people, as we know, we don't call people dipsomaniacs, or people don't refer to themselves as dipsomaniacs. Our language will change. It will have effects, but I think at these levels, we need to be very careful that we are not causing stigma, and that's really the point of all of this.
Thank you, Dr. Kelly. Along those same lines, are you aware of any research that's been done in a clinical setting where we would see some people referring to them as addicts versus people with substance use disorder? Has there been any research done to see if there are better treatment outcomes when the field itself starts using different language?
No, I haven't seen those studies specifically, and it would be hard to specifically attribute, dropout or retention as being attributable to the use of different language. That would be hard to do, I think. I think that's why it hasn't been done. The way that it's generally been studied, as I mentioned, was along these vignette type studies to look at the influence on explicit and implicit attitudinal biases. Whether that, again, this is a question that we don't fully know the answer to, but I think most people agree that, we know that attitudes correlate about 0.3 to 0.5 with behavior. There's a fairly strong correlation with behavior. So if we can change attitudes, then we may be able to change behavior. So I think the idea here is, I would predict, and I think most people would agree, that if we can help clinicians and other staff in our clinical and public health settings use respectful, dignified language, that we will elevate the self-perception, decrease shame and the self-stigma associated with these disorders, and that ultimately will have a universal, global, positive impact. And I would argue for that, even though I can't prove it.
Thank you for that answer. Hannah McDowell has another question, which I think is a great one. We haven't hit on any of the slang or terminology that we use around harm reduction strategies. And are you aware of any prior research or relevant recommendations on how best to speak in the harm reduction field? We know there's a lot of negative language used there around harm reduction.
Yeah, I think there is a lot of just, stigma and discrimination still, misunderstanding around harm reduction. I haven't seen any studies that have specifically looked at the kind of stigmatizing language around harm reduction, but I bet you you'd find similar results, depending on the kind of terminology that is used. Again, because people don't fully understand the benefits of harm reduction, they misunderstand it.
I don't see any other questions popping up right now. Oh, hold that thought. Barb Eisman does have a question. Should we talk about periods of remission versus abstinence, disease recurrence versus relapse? Excellent.
Well, they're great questions, yeah. And this has been argued. Again, I haven't seen studies looking at the effect on biases, attitudes in relation to those terms. Now, the remission, abstinence versus remission question, those are actually two different things in the sense that this is getting a bit of away from the intent of the question, but abstinence, I don't think abstinence or remission are particularly stigmatizing, but they do mean different things because you can be in remission but still not abstinent. You can be using something, some low-level use, and we do see that there is non-abstinent remission. But I think on the other side there is a lot of discussion around the term relapse versus recurrence. And there is a preference, not for everybody, and by the way, it's hard to get complete consensus on language. We have tried. I thought there would be really complete consensus on some things, but even in the best case scenario, you can probably get 90% of consensus. And that's the best consensus I have found is around dropping the term abuse and abuser and using person-first language. Most people agree that those are good ideas for empirical reasons, for stigmatizing reasons, etc. There's more debate around the term relapse and recurrence. Some people think the term relapse is stigmatizing. Other people think it's useful. I tend to adopt the term recurrence myself, except when I talk about relapse prevention. Still use that term relapse prevention for better or worse. Again, I haven't seen any studies looking at how relapse affects, the use of the word relapse may affect stigma. It might. That's less, that could be something that could be looked at to see if it does induce these stigmatizing biases in similar ways to this other abuse term. That'd be interesting to see. Maybe we'll do that study.
And it seems like you have some consensus there in our chat box too. Not really caring for the term lapse or relapse is a relapse.
Mm-hmm.
Do we have any other questions from anybody? Not seeing any other questions, I will turn it back to you, Lisa.
You actually did have one thought just as we were wrapping up. Dr. Kelly, I just wanted to share with the group really, I just recently came across the preferred terms for select populations, groups, and communities from the CDC. So it touches not only on substance use, but it's criminal justice, it's all different types. And I just want to see if you had seen that, Dr. Kelly, and if you thought it was worth sharing with the group.
Definitely, yeah.
Thank you.
Yeah, that's
I'll
a good
share that
one.
with the group.
Yeah, there's quite a few of those around now, but I was really pleased to see the CDC take that stance.
Yeah. I'll also send that to all registrants when we send out the slides and the webinar recording.
Well, yeah, good idea.
I think we might be getting one more question. Let me read it real quick.
Mm-hmm.
Okay, Suzanne asked, what are your thoughts / advice on encouraging language change in the population themselves? A lot of the discussion today has been about use among providers and professionals in the field.
Well, I think, we tend to, of course, repeat what we read and what we hear. So I'm really glad that the Associated Press, the media, is changing their tune, their language. They're advocating and prescribing now in their AP Guide of 2016 to drop this kind of terminology. And so, again, our language is changing. It will change. In DSM-5, for example, we now have the category for the substance-related conditions as substance use disorder. Now, I was told that the reason why the final nail in the coffin for the abuse terminology, which was in the prior iteration, was the research that I had done, which I presented today. So I was very happy to hear that that had that impact in really making sure that that did not get into DSM-5. Now, DSM-5 is, when was that out? Was it 2013? Yeah, it was quite a few years ago now. So again, right, now we have substance use disorder in our clinical terminology. So clinicians are going to be talking about substance use disorder, not substance abuse. So it takes time for this to change. Things like that make a big difference. I think when we change the names of our national institutes and administrations at the federal level, this has been done at the state level. I don't know what's happening in Ohio, but in Massachusetts, they changed the name from the Bureau of Substance Abuse Services to the Bureau of Substance Addiction Services. They did the same in New York State. I don't know about other states, but Connecticut did the same. But my guess is many states have started to change their language at their top level because they see the importance of making this shift in terminology. Now, when we do that, when the press, the media, when they go to the guidebook, they'll see the terminology to use. They put that in the press, they put that in the media, the people on the radio talking about people with addiction, with substance use disorders, as opposed to being drug abusers and drug addicts. That all helps, and I see that changing now. There's still pockets, and the old terminology is still around, but it's on the way out. And I think we just have to, if you're an advocate for this kind of change, speak up, speak out, let people know, write about it. We're always writing to press to let them know, emails, letters, to let them know how this language can be stigmatizing. And they're very receptive to understand and learn because they want to do the right thing for the most part. Some just want to sell advertising, but they have a conscience as well and a heart, many of these people.
I had a quick question. I was curious if you've looked into any I know when I was younger.
Sachi, sorry, can you start over? You kind of cut out for a minute.
Oh, sorry. I was just curious if you've looked into any research or if you've done any research on the difference in perception among different age groups. I know when I was younger, we had the DARE program at school, which research has shown was not effective. Excuse me. And if you think that there's anything that schools can be doing to kind of decrease the stigma and decrease kind of, I guess that was kind of my question.
Yeah, it's a great one. Great question, Sachi. Thank you. It's if you think about when I was at school, at high school, we never knew anything about what I'm talking about today. We didn't know about the genetics of addiction. We never knew, and we never really taught it. I think we have a great opportunity, and I think this is being done in some places to some degree. Now we have, for example, not at the high school level or elementary, but in medical schools now, in many medical schools, now get a load of this. This was not done until recently, that medical practitioners in their medical school training did not have to take a class or anything to do with substance use or substance use disorder, despite the fact that is probably, got to be one, if not the top, one of the most major contributors to the disease burden in most developed countries. So they're seeing every single day medical practitioners, and yet they were never trained to really understand it, to screen for it, to assess it, to treat it, to address it. They address the consequences, but not really understanding how important these causes are. Now, I think as we move forwards, I think a good idea from a societal perspective would be to embed and ensure that we embed in our educational system classes and information on the neuroscience and genetics of addiction so people understand what it is. It's a complex illness. Much of the population is vulnerable, but there's things that we can do to prevent it. And we can do a much, much better job at all of that. You're raising such an important point in terms of addressing these problems and heading them off early on. When you think about other chronic, high volume, high burden diseases like cancer, we're very aggressive about screening and detecting cancer and treating it early. We're stupid when it comes to addiction. We wait till people are at stage 4 addiction before we're willing to do anything about it. Instead of really intervening, screening, doing brief interventions early in the late teenage years and early young adult years, when that's where we see the big onset of alcohol and other drug use. And if we did a better job there, we'd be doing our whole country and families a big favor, as well as those people who potentially could contract severe forms of the illness. Thank you for that question.
Thank you.
Well, we don't have any other questions. So I think today was super valuable, Dr. Kelly. We had lots of great comments, people saying how much they enjoyed the presentation. Lots of people want to see the slides and view the webinar recording again. So thank you again for your time. And thanks to everyone for joining. We had a great response, and we will see you hopefully next month. Interact for Health does host webinars almost every month. And so we hope everyone can join us again in the future. Thanks, everyone.
Thank you, Lisa. Thanks, Sonia, everybody. Thank you. Thanks for having me.